So, Dr. Tamara Hunter is a reproductive endocrinologist and gynecologist who graduated medicine in 2000, following practice as an exercise physiologist and corporate health consultant in Sydney. Dr. Hunter also received 2 academic awards for her work in women's health, written several research papers and books on ovarian health, and is a television spokesperson for women's health. So today, Tamara, I want to share your expertise with women's reproductive health. While most of us may have retired our reproductive years, we can maintain a healthy momentum, albeit on a different path. So thanks for joining us, Tamara. I appreciate it.
Pleasure.
So as a gynecologist, what is the most common condition a middle-aged woman, I know that's a broad demographic, presents with in your clinic?
Yeah. So let's just call middle age at the moment 50. No, it's just an easy cutoff. It's an arbitrary cutoff because middle age for different women can actually be at different ages and stages of their life. But let's just call it 50 for now. I would say the majority of women who are over the age of 50 have probably already been through or starting to go through menopause, and you can develop, as a result of having no estrogen left in your system, conditions that affect different systems in the body. And the most common that I would see over the age of 50 is women coming seeking assistance around urogenital symptoms. So when I say urogenital, involving the bladder, involving the vagina, involving the vulva. And so that could be anything from urinary urgency and increased frequency, getting up several times a night to go to the toilet, causing sleep disturbance. It can be a dry vagina and just feeling uncomfortable. It can be painful sexual intercourse, which ultimately then affects libido and relationships. It can be just an itchy vulva because the tissues aren't quite as supple as they used to be. And all of this happens as a result of there just not being enough estrogen around anymore. And, you know, these conditions, they're hard to talk about. They're hard to present with. And so it'll often be that they'll come talking about hot flushes or weight gain or mood changes, but then the very last thing that they'll say to me just 5 minutes before they walk out the door is, oh, by the way, because it's such a difficult, uncomfortable thing to talk about.
It is. And I think, you know, it is because we're never really taught to talk about it. Even periods and all of that journey, you know, is sort of discussed more now probably than when I was younger, but we really haven't learned just to speak about it. No. So how do these really uncomfortable conditions impact women's lives?
Oh, enormously. So menopause itself, by definition, is when you've had 12 months of no further periods and you've got hormone levels suggestive of the ovaries no longer working, so ovarian resistance. So that's the definition of menopause. But you can have menopause-like symptoms that develop in the years leading into that time and the years leading beyond that, because there's no or very little estrogen around. So all of the tissues in our body have these estrogen receptors. And so if they're not seeing estrogen anymore, then you can get these symptoms. So the urogenital ones are the first one. And as I've suggested, they can cause physical discomfort, they can cause relationship discomfort, they can cause sleep disturbance, which, as we know, affects our mood. So anxiety, depression, mental health. So they can hugely affect the rest of our ability to function. Then there's a group of conditions called the vasomotor, and these are the most common that menopausal women present with, things like hot flushes, you know, inability to tolerate heat. And so if you're constantly taking off the blanket and putting it back on and taking it off and, you know, fanning yourself in the middle of a business meeting or whipping off the jumpers, all of that can get really exhausting if it's day in, day out. And then the other group of conditions tend to be what we call the psychosocial conditions. So they can be irritability, emotional lability, you know, shouting at your husband, your kids for seemingly unimportant reasons. So the real mood-related things. And then there's some somatic conditions like joint pain, crawling skin, muscle aches and pains, hair, skin, nails, weight gain. It sounds terrible, doesn't it?
It's never ending.
It is.
Never ending.
All of these things affect how a woman feels about herself, how she relates to other people, and, you know, her ability to perform in her day-to-day life.
Absolutely. Now, are all women affected by this estrogen deprivation? Or do some women sail through this?
Look, there are, and we hate them.
Totally hate them.
The reality is it's probably only about 10%, 15% at best, women who have absolutely no problems going through this stage of their life. But it's important to remember that it's not just about the symptoms, how you feel. It's also about the long-term health issues as well. So I actually think every woman has to manage this phase of their life in some respect.
Yeah. I think that's the thing, and I'm going to jump to something, but before that I have later. But when it comes to this and we're managing it, you know, of course, HRT or HT as it's now known, hormone therapy. I am a huge proponent of it because I thought it was the best thing ever. But I'm still hearing women say, you know, oh, you know, it's too dangerous and all those sorts of things. And I thought to myself, if that's the small risk I'm going to pay to be sane, then that's going to be it. So when we talk about them, I mean, I'm going to jump straight to what are treatments, or how can we manage those symptoms at home before we even need to approach or come to the doctor? And if that's not possible, what are some of the treatments?
Okay, so let's talk about the lifestyle stuff first, and then I do want to talk about menopause hormone therapy because it's important to get this communication right for women. So lifestyle is an essential part of the management of the menopause. We know that metabolically things change. A woman has an increased risk of cardiovascular risk issues, so heart attack, stroke, type 2 diabetes. That's all part of the what we call the metabolic syndrome, and that risk goes up when a woman is postmenopausal, kind of to align with what the risk for men is. And so lifestyle factors, maintaining weight through cardiovascular exercise, maintaining a good diet. We prefer the Mediterranean type diet is the one that is recommended for heart health. Doing weight-bearing activity to help with bone health in the long run, making sure they're getting adequate calcium in their diet through consuming enough calcium-containing foods or supplementing. So they're just a few things that are really important to maintain the long-term health and well-being of not having any estrogen around. So lifestyle is absolutely number one when managing long-term healthcare. Now, as far as the symptoms of menopause, so the urogenital and the psychosocial and the vasomotor, then lifestyle is similarly important. So weight management and exercise is important for musculoskeletal pain, also for mood. It's a really, really important thing for managing mood. Good sleep hygiene, not going to bed with electronics, having a good ambient temperature, all of those things to ensure that if you're going to have poor quality sleep, you're going to do the best you can with your sleep environment. So lifestyle is vitally important.
So we have to own our own health journey in that respect. That's the line for, the tagline for us, because we really, and the reason I sort of started this is to share so that we can own our own health journey, and lifestyle is obviously the massive part of that, and not just running off to get, but of course then there are times when of course that's just not enough and we do need to supplement that. Yeah. So then what happens? What are some of the suggestions then?
Okay, so let's talk about menopause symptom management. So there are certain populations who are postmenopausal who need to have menopause hormone therapy because they have certain conditions. It might be around bone health issues. It might be that they've gone through menopause way earlier than they should have, and so should be seeing hormones up until the average age of menopause, which is about 51. But the vast majority of women need menopause hormone therapy for symptom control. The debilitating hot flushes, the terrible menstrual migraines that they're, increasing frequency, the horrible urogenital symptoms. So there are women that require it to function on a daily basis. It's not the devil. Menopause hormone therapy 20 years ago was studied in a really large study called the Women's Health Initiative. And the initial review of that study suggested that women who take HRT, as it was termed, have a slightly higher risk of breast cancer and risk of clots in the legs, lungs, and brain than women who didn't. And the media took hold of this, ran with it, and all of a sudden there was this propaganda that menopause hormone therapy was the devil. What is really amazing is that over 20 years after that study publication, the results have been analysed and subpopulations have been analysed. And the ultimate summary that we've come to is women on menopause hormone therapy have no greater risk of death or mortality than women who don't take it over the long term. So I see generations of women who have been denied menopause hormone therapy as a result of that study and have just had horrible lives. They've had to battle their way through these horrendous symptoms for no really good scientific reason. Now, in saying that, can everybody take menopause hormone therapy? No, there are risks. You know, if you're a smoker, if you are morbidly obese, if you have a clotting condition, it is important to see someone who understands menopause hormone therapy, assesses your risk profile, and decides how to give it to you, because there's lots of different ways we can give menopause hormone therapy, how much to give you and how long to give it to you for, but also implements all of those important screening processes to reduce your risk of complications.
But, you know, they sound like the same risks that are associated with the contraceptive pill.
Yeah, very similar.
Oh, you shouldn't smoke. You should, well, obviously the weight, it seems similar. Yeah. But yeah, we the devil was in the HRT, and someone said to me the other day, I was just saying this to somebody else, they said, I've just got to thank you. And I said, why? She said, because I went and got some HRT and I've never felt better. It's been life-changing. Yeah. And yet I have seen, as you say, my generation, people suffering because they thought it was going to kill them. I thought I'd rather be dead than live like that. It was unbearable. So I don't know. I just think it's something that we should be sharing. And obviously with the risk profile, you take that into consideration.
Yeah. And there are some alternative preparations that have been proposed to maybe do the same thing. Unfortunately, none of the research that has been done, nothing has been shown to do anything other than placebo. But you know what? If placebo works for you and you're happy with that, then that's great. There are some bioidentical products that have been proposed to do the same thing. My only suggestion to people is to make sure they do their due diligence, because whilst there may be some efficacy, the harm profile, the risk profile of these preparations is not clear. So I would strongly suggest, if you're thinking about it, go and talk to your GP or a GP who understands menopause hormone therapy. And if not, escalate it and talk to a specialist.
Yeah, well, that's what happened to me. I think it's important to share, because my GP then put me on to a specialist at the Royal Women's Hospital in Sydney, and I got the lowdown and was able to make an informed decision. But yeah, I feel for women who haven't sort of taken that up, because it would be bloody miserable. Okay, so all right, sorry, getting back on track. I could go on for hours on that. Okay, so I think, what I was going to say was, do you think a lot more women are living with these than presenting with those, particularly the genital conditions and, the places that we're concerned of a bit shy of?
Yeah, I think so. I think that a lot of women suffer in silence. I can't tell you the number of women who come into my office and just it's this sense of relief that they've found someone who understands what it is that they're going through. So that whole, I'm the only one that's suffering from this, and this is really embarrassing, and I can't even talk to my husband about it, and there's something wrong with me. There's something, this is pathology. It's not. It's a phase of our lives. We should celebrate it. It's our stepping into wisdom. We are becoming wise women. We're, experiencing this. We should be able to freely talk about it, and be able to access education and empower ourselves with that knowledge.
Yeah, exactly. And get whatever treatment or management's required and get on with your life. I mean, who wants to be sitting around, dealing with all of that? Okay, so I'm actually going to take a little change of tack here because I think it's also important. I mean, you've got so much information, but I am going to get onto osteoporosis. So another common condition in women that can be challenging at this stage is osteoporosis. Who is most at risk, and how can women protect themselves from deteriorating bones and joints?
Yeah. So again, one of the most important hormones for osteoporosis is estrogen. Estrogen helps us to lay down the chemicals or minerals that are responsible for our bone integrity. And once there isn't any estrogen, either exogenous or endogenous, within us, our bones have a greater predisposition to break down. So all of us reach our peak bone mineral density in our mid-20s. So the very first thing is you've got to reach that peak bone mineral density. And there are conditions that young girls suffer with in the same realms as things like eating disorders, low body weight, over-exercise, that will suppress their ovaries' ability to produce estrogen. And these girls don't even reach their peak bone mineral density. So that's the first population. If they're not having regular cycles, and I'm not talking about the girls on the pill who miss their periods, I'm talking about the girls who almost put themselves into a temporary menopause due to lifestyle changes. So we call that functional hypothalamic amenorrhea. They lose their periods because what body wants to reproduce when it's a time of war and famine?
Yeah.
So it's this evolutionary thing to protect us, but unfortunately, it compromises our long-term bone health. So we've all got to reach in our mid-20s. So very, very lean women who don't have a lot of body weight are at higher risk of developing osteoporosis. Women who don't do any weight-bearing exercise, and that can be as simple as going for a walk, are going to be at increased risk. Women who deny themselves calcium-containing foods, so those people perhaps who don't have dairy but then don't necessarily supplement something that is calcium-containing. And that's at any stage in our life. Smokers have a higher risk of developing osteoporosis. And then when you hit the menopause and it all starts to really drop off the precipice, it's the weight-bearing exercise, the calcium-containing foods, the muscle strength, which puts strain on the bone, which helps us lay down more bone. All of those lifestyle things are really important. Yes, there are genetic conditions. We know that women who have a family history of osteoporosis have a higher risk of getting osteoporosis. So there is that familial relationship. But if you're doing all that you can from a lifestyle perspective to maintain your bone integrity, then you should do well.
Interesting that you talk about taking it right back to the 20s, right? Because, this is all about, trying to warn women and remind women that they need to start taking care of themselves in their 40s. But actually, it really does go back a lot earlier than that. Yeah. But I think we all think we're invincible, of course, in our 20s. Yeah. But I suppose they can at least forewarned again. Okay, well, I was going to talk about that and the effects of the conditions. So, all right. So every woman, of course, should have an annual checkup throughout their life. But of course, is it more important as we hit our 40s? And what should we be seeking from our GPs? I mean, I have just, and I'm keep using myself as an example, but I moved from Sydney up to here, and you go through a few GPs while you sort of try to find the right one. And what should we be seeking from them? Because again, I don't think we're well equipped to be asking the right questions.
Yeah. So, wow, let's unpack.
Those are big questions.
A can of worms. I'll say up front that I love how we have evolved our cervical screening program such that women who don't have any HPV don't have to have a pap smear for another 5 years. That's fabulous, However, what it does mean is that women are going to their GPs less often. And so the important screening things are not necessarily being done. COVID certainly hasn't helped us in that respect either, because women are choosing not to go to their GPs. for lots of various reasons. So, and making a commitment to yourself to having an annual review with a GP who you know. I can't tell you how important that relationship with that GP is, and not just seeking a sort of after hours 24-hour care, because having that long-term relationship is key. So screening things are really important. Skin screening. Skin cancer is still one of the biggest killers in Australia. It doesn't really discriminate. And most of us going through our 40s now were kids that were exposed without any hats or T-shirts as kids. So skin cancer screening is really important. Of course, the PAP, which we call cervical screening, is really, really important. Breast checks. Oh, my goodness. Doing a breast check.
We do it well enough, really. I'm not sure that we know how to do it properly.
No, and there are kits, the Jean Hales Foundation, which is an amazing resource.
Yeah,
have some great education on how a woman can do it. Now, when you're premenopausal and you're having a period every month, that's how I remind my patients, make sure whenever you're having a period, let's do a breast check. But when you're no longer having periods, you've got nothing to remind you. And if you're having a pap smear every 5 years instead of every 2, so, having some sort of annual check-in with your breast check is really important. Blood pressure, cholesterol, triglycerides, sugars, all of that metabolic screening is really important as well, because as we become closer to menopause or even postmenopausal, our cardiovascular risk profile changes.
Yeah.
What
about things like thyroid? I've got a theory, my very limited experience. But, I often think that it's often under pressure because of the stresses and the mental load and everything that we deal with. Sometimes it comes out to say hello in a very unfriendly manner. Is that something else we should be checking?
Yeah, thyroid functions. So the most common thyroid dysfunction is underactive hypothyroidism, which can lead to things like fatigue if you are still having cycles, very irregular cycles, heavy cycles, weight gain, cold intolerance. That's if it's really severe. But even subclinical hypothyroidism can be an issue. Up to 1 in 3 women as they get older will develop hypothyroidism. So, having a screen for those sort of things. And then, as we age into our 50s and 60s, the rates of certain cancers do increase. So, if you're having bleeding post the menopause, you must get seen. If you're having bleeding after
possible too, right? Yeah.
Bleeding after sexual intercourse, not normal. You must get
right.
seen.
Yeah. Okay. Yeah. See, that's really interesting. I think women would probably just go, oh, well, we'll just let that slide. All right. So this nasty, well, it wasn't nasty, but the estrogen, of course, that's finding it's running away, is obviously something that we need to. So what is, and it's probably hard for you to say this, but what would you suggest for someone who, let's say they've been through menopause and they're out in postmenopause and they're finding that their estrogen levels are too are limited, or things hurt or whatever? Do they stay on a hormone replacement, or is there something else? Is there another sort of step to go through? How does that work?
Yeah, so the Australian Menopause Society has very clear guidelines, and any woman can go and check out the AMS website, menopause.org.au. I'd strongly encourage some fantastic patient resource sheets. But our general belief is that menopause hormone therapy is commenced around the time of menopause. Ideally, we shouldn't aim to progress it beyond about 5 years post the menopause. We should give it to women in a way that has the best risk profile, so the least harm, and that generally is a transdermal, so patch, gel, cream, so topical. There are tablets, however, that you can take as well, but generally speaking, the lowest risk profile is with the transdermal preparations in the lowest possible dose to treat the symptoms, and with the intention to wean off by around about 5 years.
So that's the thing. Oh, sorry.
Yeah. So I was just going to say, there are some women that can't wean off it. There are probably a good 10% of women who will never get off menopause hormone therapy.
Yeah.
But if you're connected with a specialist, someone who understands the risks, someone who is constantly assessing the risk profile for you as an individual, weighing up the pros and cons, I have women on menopause hormone therapy in their 80s.
Yeah.
Been on it for 20 years, can't get off it. So
it's an individual, it's individual, obviously. But I was wondering if there was something beyond that.
Most women can get off it. Most women can get off it. And then we look to the other things. So let's come back to those urogenital symptoms, for example. You can use local vaginal estrogens, which are much lower potency than, say, the oral tablets or the topical patches. So we might, if the symptoms are just isolated to that area, we might use a local vaginal estrogen cream or pessary. We would introduce vaginal moisturizers, just like you moisturize your face every day, vaginal moisturizers. We might introduce you to a physiotherapist to help deal with some of the things like painful intercourse or perhaps bladder retraining. So there are lots of really multidisciplinary things that we can use to help symptoms long term.
Yeah, that's good. Okay, because I wasn't even sure about that. And I thought, well, how does that work? All right, well, let's take it back a step in terms of when we start this process. So something I feel that is even lesser known than menopause is perimenopause. So what is it? What is the average age for this to begin? And what can we expect from that?
Yeah. So the average age of menopause is 51. But if you think of a standard deviation, a standard distribution curve, you've got one standard deviation, two standard deviations. So really, normal menopause can be anywhere from 45 to 55. That's normal. Yeah. Now, some women are just getting going at 45. Yeah. I have fertility patients at 45. So I do think psychosocially, we've kind of like moved everything, sort of 40 is the new 30, 50 is the new 40.
Absolutely.
So for some women, it's devastating thinking that at 45 they're going through menopause, but that's actually normal. 2 standard deviations is down to, early 40s. So the perimenopause, which is the years leading into that time when your period stops for 12 months, that can go for a few years.
Yeah.
So it's not unusual for me to see a 41, 42-year-old woman coming in to see me. She's got an 18-month-old because she's just had fertility treatment. And I don't know what's wrong with me. I can't sleep. I'm yelling at my husband. I don't want sex anymore. And I'm like, I think you're perimenopausal.
Yeah. So, and that's of course just preparing you for the menopause.
Yeah.
But so soon. I had speak to other women, they're like, what? I just said, see, it's so really we need to start. And I just think that the more we're aware of it, the better we're going to be prepared.
Yeah, definitely.
So so getting on to then the menopause, the oft live in denial life transition for women seems to be frequently swept under the carpet. What can we be doing? Well, I think we talked about that actually. What can we be doing in early 40s? It is about lifestyle predominantly, and we need to be taking care of ourselves. And when we're usually running businesses and raising families and doing all those sorts of things, it's critical.
Just on that note about the perimenopause, and this is a misconception I'll often get, is that it's actually okay to start menopause hormone therapy even if you're having periods.
Oh, really?
Yeah, absolutely. Because in the perimenopause, so let's say your estrogen level is here and no estrogen is here, the perimenopause, your estrogen will sit here.
Right.
And so those little receptors and all of those tissues in your body are going, hello.
Yeah.
Not right here.
Yeah.
Disturbance, hot flushes kicking in,
exactly.
Weight gain, and so menopausal migraines. So it's not uncommon for me to start menopause hormone therapy in the perimenopause, even if they're having cycles.
See, that's good to know, right? That's, because I think they just think that we've just got to wait until the start of. Okay, I was going to talk to you about the cervical screening test, but do we need to have I'm going a little bit off here, but do we need to continue to have CSTs, cervical screening tests?
Perhaps? Absolutely, yep. So the Australian guidelines suggests that a woman should continue to have cervical screening up until the age of 70.
Okay.
Beyond that, if you've got that far, you've done well, gold star.
Yeah, exactly. Really, all bets are off at that point. Okay, so I think we've talked about that, and we've actually talked about that. So you beat me to the punch on a lot of those things, Dr. Hunter. So we do continue to be learning about life transition that has been hidden for so long, and it's been around since the beginning of time. So I don't know why. But I feel like we've only just scratched the surface, to be honest. But I want to thank you for joining me today. I'm sure our audience will be really pleased to get this information. So I just look forward to continuing to learn, and hopefully you'll join us again on another topic.
Definitely, Lindy. Thank you.